So welcome everyone to this debate. This is part of the Science of Pandemic Tech series. Normally we focus very much on the science in this series, but in this time we have something different. We have more of an interdisciplinary conversation that includes science, it includes tech, it includes humanities, it includes the social sciences, because we're going to be talking and debating decisions that have been made in the past and will be made in the future that require that sort of interdisciplinary high-level dialogue to really move forward on. So this series, as I said, it's supposed to be trying to do pandemic science at pandemic speed. This time it's a little bit more retrospective and a little bit more contemplative and perhaps next pandemic oriented, but it's very, very much interdisciplinary and still about, what technology can do. And it's a debate. And it is a debate between two of the founders of the idea, the pioneers who came up with the first decentralized protocols for notifying people of their exposure to COVID. Camilla Troncoso, who worked on DP3T, and James Petrie, who worked on CEN and TCN and co-founded COVID Watch. And so the decisions that need to be made about these protocols are technical decisions, and so we have two technical people as our debaters. But it's also important that we listen to more voices, which is why we have a bunch of respondents to weigh in. Peter Singer on ethics, Louise Ivers on public health, Jason Hong and not Alyssa Redmellis as originally advertised on user acceptability, and Jane Baumbauer on law, because all of these things matter. So as for me, I am a professor at the University of Arizona, applied mathematician of sorts, who was figuring out how to communicate evidence-based medicine at the time and have been involved in risk analysis. And together with Luca Ferretti, I run this series. James Petrie, as I said, he's an applied math student as well as doing research at WeHealth as well, and founder of some of having the foresight to start working in January 2020 on decentralized Bluetooth protocols. And so he's been involved from the very beginning of all of this, as has Carmela from Switzerland, Carmela Troncoso, where she's a professor in Lausanne. And a real award-winning expert in all kinds of questions related to privacy protection. For our respondents, we have Peter Singer, which is particularly meaningful, I think, to James and many of the members of WeHealth who trace back to the COVID Watch days. COVID Watch was actually born through conversations on an effective altruism platform, where Peter is something of a patron saint. Apart from that, he has been described as the world's most influential living philosopher, and he certainly influenced the founders of COVID Watch, and we're very happy to have him here. Louise Ivers, I think it's really important when we talk about digital solutions and supplements and alternatives to contact tracing to have somebody in the room who actually knows something about how normal contact tracing works. That, we do not want to be disconnected from the realities of facts on the ground and what the people who do it for a living mean. And she has enormous experience in global health and infectious disease, and can ground all of these to represent the perspective of what we're actually doing in public health and what public health people know works and doesn't work. Obviously, everything has to stay within the bounds of the law, and we have Jane Baumbauer, who's written extensively on privacy-related costs and benefits and so on of big data and what's possible. And so we have her representing the legal perspective, and Jason Hong representing the user acceptability perspective. He's worked extensively in the space of privacy technologies and user acceptability, and just completed a large national survey of people's intent to use this technology and the factors controlling that. And so there were some pre-debate discussions before we got into this, and What was really interesting in the pre-debate discussions between Carmela and James is how much they agree on. And one of the things they agree on is that this isn't really about privacy versus effectiveness. It's effectiveness versus the danger that the technology will be reused for certain mass surveillance purposes in the future. So it's not really about exactly how private is the current protocol in its current application, but rather what sort of technology are we building, and if we unleash it, what will it do next? And I thought it was really interesting that both agreed on what the problem was, and it wasn't exactly the same as how it's usually phrased. And they agree this is a list of the various rules that are there to prevent privacy and prevent malicious reuse. And they agree on most of them. But there are some points of disagreement about opting in for download, which is sort of more of a question for the next pandemic. And then some technical ones on the amount of metadata and the ability to upload certain cryptographic keys to public health agencies. And so that's sort of two of the points that there's going to be disagreement about. This is really a debate. James also would like to access Wi-Fi, but that conversation is far too technical to have in this kind of format, and so we won't be talking about that. And Louise signaled that she's not convinced about the restricting entitlements to public health authorities, and so we welcome her to bring that up as a respondent as well as something to challenge. But I think, you know, the antagonists agree on this slide that these are the issues. So with that, I will hand it over to Carmela.
Thank you, Joanna. Let's do the sharing screen dance. And let's ask, do you see my screen?
Yes, we can see it.
So we're going to spend a little bit, as Joanna said, this is retrospective and a bit of how we got here. I have to say now I come here to express my personal opinion. I'm not talking on behalf of my employer or any of the groups I belong to. And I want to speak today about the design principles that led us to propose the Decentralized Privacy Preserving Proximity Protocol, or DP3T. So everybody's like, okay, the problem was that in the beginning of the pandemic, contact tracing was overwhelmed. It started not being able to hold. And everybody started talking about the solution that is an app to leverage the phone sensors to help contact tracing in this endeavor. And when we were presented with this, and when I say we were presented, is because it was never my idea or wish in the world to actually build an app, but the app came. But when we saw this, we didn't see, we want an app to leverage phone sensors. That's what normally people think and users think. There is an app, there is this thing on my phone. But actually what we were asked for is to build an infrastructure that could leverage phone sensors. And this infrastructure means that we not only have an app, we have a network, we're going to be backends to support this app. We're going to have a user interface towards health workers, not only account the user, because we are involving people that are positive. We need to connect to the result of a test. And also because we build an infrastructure and we needed to build it at the speed of light. Like this was one of the projects that faster in the world of going from inception to development. Like even if you think about lean or agile methodologies, what happened here was not agile, it was beyond that. That meant that we had to create existing infrastructure and as such create a lot of dependencies on the mobile operative system. If you're going to build an app, I'm sorry, the operative system is going to rule on you. We used cloud infrastructure, in particular in Switzerland, not so much, but many other countries have their servers in the cloud. And most of these things are privatized because the health system all around the world has very little infrastructure of their own. Infrastructure not to, I don't mean infrastructure as in a hospital and to run the hospital. I mean infrastructure that could actually hold an app that everybody could have on their pocket and could communicate with other apps at a scale that was unimagined before for a health application. And why it is important that we think about this, about an infrastructure instead of an app? It's because infrastructure, once you build it, is harder to move. Digital infrastructure nowadays is like a road. We put it there, and then good luck removing it. Once the road is there, it's going to be used. And it's not only going to be used as in people want to use it, because it's a new road. We also see that people are going to try to make you use it more. And even when it is abandoned, okay, and one like maybe a highway appears on the side and the road is not so much used, the road still exists. And Google have a legacy road that people may still use or maybe may have to use if some dependencies have been created. For instance, imagine that there is a factory whose only access is this road. Digital infrastructure is the same. And infrastructure, once we build it, is very hard to control. And when we said this last March, and people were saying, well, maybe you're a bit exaggerating. Well, if we look in the past, right, and here are news from last March to January this year, we see how increasingly data associated to COVID tracing, whether it is on physical form on paper or on digital form on apps, has been used by both people like bartenders, people that were using these papers, as well as law enforcement for purposes that are not the ones that were intended for this type of apps. So with this in mind, we tried to limit the infrastructure that could be built. We cannot control it, so at least let's try to mitigate what can happen once this infrastructure is there and can be used to other things. As such, we relied on decentralization to hide the kind of information that we know for history, right? Not only these apps, of how the digital world has worked in the last 10 years, where the collection of personal data is more and more reused for different things, that the things that we reuse are identity, that allows us to link things to people, their location, that tell us a lot about the people, and relationships. One of the most important, who talks with whom, right? If we go back and look at the Snowden revelations and what kind of information is really relevant, we see that it is metadata, locations, and relationships, something that sometimes is much more important than identity. And then we wanted to build something that is limited on purpose by default. That means that the design really limits for how many things you can use it. And it was decided that it would do only proximity notifications. That was the task that we were given, help increasing the speed and the scale of notifications. As such, there was no room for collecting epidemiology research data. It's very nice. It would be nice to have some of those things, but we're having a non-pharmaceutical intervention, and we needed to limit it so that it would not create more damage and it still would help. And augmenting the purpose, we built it in a way that has high cost, because it would require changing the infrastructure. And not only it has high cost, it also becomes transparent, as opposed to many of the systems that we have nowadays, where data is on a central server and the data is reused again and again. And we don't know how, we don't know if it changed or not, because we cannot see it. In this system, if there is any more data collected, we can observe it, because the system is so limited that they have to change the infrastructure. And as this, we wanted to minimize the abuse possibility. One was this increasing the cost of any modification and this transparency that allows us to scrutinize the system all the time, and also make it voluntary for users. Because if you make something mandatory where everybody participates, it's more likely that it's going to be abused, because the power that it has kind of is infinite, right? If we have this on the pocket for everyone. Where we are right now, indeed, we managed to limit the infrastructure, but it's still a strong power imbalance. As I said in the beginning, if you build an app, you are in the hands of the mobile iOS. And we have a strong dependency on Google and Apple on the decisions, what they decide on the API, some of the things that we're going to decide today. And this has influenced how epidemiology is done, as well as some privacy decisions. This was not in the design. This is what Google and Apple decide. And this does not stem from architecture. This stems from them being the owners of the operating system and always decided what is going to happen in there, what is published, and how it works. And the app has had, in many cases, limited impact. But this limited impact, we know that it's not about the protocol and the decision. Integration in health systems was not easy, and is still not easy. And a lot of it stems again because the digital infrastructure in many health systems, I cannot speak a lot about Europe. I don't know much about the US, but none of them, or most of them, were not really prepared to connect to this infrastructure. And the data is low. Some people just think it is not needed at all. Some people think it doesn't work. Some people still think, oh, my privacy is going to be violated by this app, even though it's the less privacy invasive app probably that they will ever have on the phone. On the other side, the good news is that we have the first positive performance results. Reports in Switzerland and the UK show that the app is indeed effective at breaking infection chains. The infrastructure provider, even if they are still in power, is in the open. They had to come out and demonstrate how powerful they are, so much that they can actually kind of bend over the states and tell the states what they have to do and how they have to do it. And there is very limited service for stealthy abuse, because imagine that we had all of this data about who is with whom in crisis events that we had in the last year, like the Black Lives Matter or the Capitol riots. If we had this social connection tracking and all of this data on a server, what would have happened? And with this, I'm going to end my intervention now and looking forward to hear what James has to say.
And I should say that these two speakers get to speak again at the end, and going over time may limit that. So James, with that in mind, take it away.
Sounds good. Okay. So in the first segment, I'm going to talk about 3 proposed adjustments to the exposure notification system. So to put this in some context, a lot of places have rolled out an EN app, and the UK recently released an analysis showing a strong positive impact. In particular, they estimate, wait, sorry, I have to go back to this slide. In particular, they estimate about 600,000 cases were averted. So in that context, even a small fractional improvement to the system could have a large impact. And so we should think about that very carefully. Because if it were to improve by 30% or so, that's another like several 100,000 cases prevented. And I agree with Camilla and that a decentralized system minimizes most of the security risks. So I think in combination, we have a system where there aren't that many security risks, and we have a lot of room to optimize for the health outcomes we want. So I think there are a few things that we could do a little bit differently. So the first one is more metadata. In a recent preprint, we talk about the value of information and how knowing who's at risk and quarantining exactly those people reduces the amount of social distancing the rest of the population has to do by a significant amount. And in this context, we're interested in the risk associated with an exposure notification and how many levels of resolution there are. And we estimate that increasing that resolution from 2 levels to 8 levels can increase the benefit of the system by about 30%. The next one to talk about is adoption. So right now it's a completely opt-in model. But I think in some other contexts, opt-out models have shown like much higher adoption levels. I'm not recommending that it become mandatory, but I think that there's a large portion of people that either don't know how to install the technology or don't really want to invest the time to investigate it and then install it. And that getting over that inertia would have a large social benefit. But also that the system is so private that by doing that, we're not causing harm to these people by opting them in, and to do so in a transparent way. However, there are technical reasons this is difficult to do, among other reasons. So even if we wanted to, it probably wouldn't be possible in the next few months. But I think it is something we should consider for future scenarios, much like an emergency alert system. It's just something that's enabled by default. What we can do right now is incentivize usage. I think the UK has done a pretty good job with this, with not making it mandatory, but making it easier for people who have the app. They don't have to sign in at restaurants or things like that. And because adoption is so important for the use of the system, it's both the contact and the infected person have to have it. Doing something like this would make it a much more effective system overall. Another one I want to talk about is opt-in case linking. So right now, exposure notifications are completely independent, or not completely, mostly independent from manual contact tracing. And I'd like to provide an option for people to share their information with contact tracers, and to do this in a way that allows contact tracers to link cases and people who infected them. Because there's a lot of benefit to being able to find clusters, do backward contact tracing, and just to reduce duplicated effort. So briefly, I think this is a quick example about backwards contact tracing, where an exposure notification is sent out in the normal way, but the person who gets the notification is able to send extra data to the public health. And that allows them in their system to see exactly who sent the notification to who. This can be done in a decentralized way, but from public health's perspective, they'd enable a notification to be sent out. And then in their system, a few hours later, the contacts would start to appear in their software, and they'd see the risk associated with each person, contact info, phone number, and they could investigate further or pick which people they don't have to follow up with. So technically, the one thing that we need to change there is that we need to be able to share a bit more data with people who get a notification, to be able to share the keys that they matched with. And this can be done relatively securely by using some public key cryptography. So you can even have it so the people getting notification can't see any of this extra data. It's just which key they matched with could be sent privately to the contact tracers that are relevant. I can go into more detail on this later if there's interest. So in summary, I think that EN has had a large impact and can have an even larger impact, and that decentralization prevents most of the issues, and that we should think about the trade-offs and not necessarily always pick the safest option. And I'll hand it over to the next speaker now.
Okay, and the next speaker is Dr. Louise Ivers, who will be giving us the perspective of what at least she, on behalf of public health, think about this.
Yeah, thanks very much for inviting me. Obviously, I'm just one person in a vast world of public health, and I'm also in the United States, which has had a different experience overall, I would say, than Europe and other places with this technology. And I'm also in Massachusetts, which is a state within the US that has not deployed the use of this technology yet, although it's kind of under consideration at the moment. I do want to say that the only reason I'm even vaguely involved in this work is thanks to some newfound colleagues at MIT, Professor Ron Rivest, and computer scientists and engineers, and I spent a lot of time working with them. But what I will say is that I think in some ways what I'm about to talk about will help you understand that for many people in public health, this is a very kind of confusing debate in some ways. Many of the things that James highlighted in terms of the usefulness of the technology are what we need. Contact tracing is a social, behavioral, epidemiological intervention that has humans and humans normally. And I think one of the challenges has been that the technology innovation on one side really, was failed immediately to embrace the kind of holistic nature of contact tracing, but also public health gurus and the dogma of public health really failed, at least in the US, to embrace the opportunity of the innovation significantly. And the lack of this coming together in the early days, I think, in many ways for the US anyway, has been a challenge. I think in terms of the privacy and effectiveness discussion, the private sector, public sector interactions and partnerships are already complicated in public health. And I think there's a lot of trust, lack of trust, mistrust. There's a lot of power dynamics, and Carmela, you mentioned these as well, that are really important. When I question the fact that only public health authorities are allowed to use the technology, I think I endorse wholly a public goods, a public health approach. I can't really imagine a pandemic response without public health being a leader of that. But at the same time, the way that Apple and Google made this available is that only one public health authority in one place could do it. And so in Massachusetts, for example, we have 351 towns and cities. Each of them have a public health board. And so we couldn't even really do early adoption, early piloting. It was hard to get some real world use without going kind of all in or all out. I think I said it was a bit confusing, the debate. I don't think that the concept of the technology is confusing, but when you get into the nuance of it, and when you start talking about the texts and which bits of information are you sharing, people like me, I'm an infectious diseases doctor. What I understand about privacy is that normally in contact tracing, we do engage in a privileged and private conversation with the individual. There is an exchange of private information, but it's obviously not held in a way in which it is at the same way at risk in terms of security. And so I think some of this debate gets to a technical level that can be hard to interpret for more lay people like me. And then I think when you get into the nuance of dialing up and down the different pieces of the API and the exposure notification, it's hard for me even to understand, well, how much of a difference is that going to make to its effectiveness, and how much of a difference is that going to make to its privacy? The last comment that I want to make is just about equity. 19% of Americans do not own a smartphone. And what we've seen in the United States is a dramatically high impact of this pandemic on Black communities, on Latina communities, and Indigenous communities. And a lot of the overlap in lack of phone ownership is also overlapping with, the elderly, the differently abled. And so I think in thinking about how this technology could ever be used in an equitable way, I just don't feel like that has come into the conversation very much, although I know that's not really about the privacy versus effectiveness, but I just want to put it on the table before I pass the mic to the next speaker.
Thank you very much. And the next speaker is Peter Singer, representing ethics.
Thank you very much, and I'm happy to try to bring in some of the ethical considerations into this discussion. I think obviously behind this question lies, the issue of how much do we value privacy, and that's going to be something which, as a matter of fact, will vary from place to place, from country to country. But I think we can also ask questions like, well, how much should we really value privacy, and how important is it? How much difference does it make to our lives, positively or negatively? And I'm inclined to think that in some countries, and the United States is perhaps one of the best examples of this, there is a sort of exaggerated perspective about the importance of privacy as compared to other things. That the example here that we can obviously look at is the discussion about the revelations by Edward Snowden that the National Security Agency was collecting metadata on phone calls. So there was a purpose to this. The National Security Agency was trying to avert terrorism, I suppose, was the major reason for doing this. And there was a lot of outcry when Snowden exposed this, and things went to the courts, and one of the courts did actually say that this was unconstitutional. But that's a legal question, and we'll be hearing more about the law in a moment. It's not an ethical question, because it may be that the US has a constitution that, interpreted by the courts, says that this is unconstitutional, but maybe that's a mistake. I mean, I think if you interpret the US Constitution's Second Amendment as saying that everybody can own a gun, that's a terrible mistake. So possibly this is a mistake too, and also one which could have very serious consequences if it stands in the way of preventing major terrorism. So if we look at this case for contact tracing, again, the consequences of not doing contact tracing can be very serious. James Hong just quoted the National Health Service in the UK's claim that perhaps 600,000 cases can be averted, and he suggested that better contact tracing could avert more cases. So we're talking about a very substantial number of deaths. If we're talking about 600,000 cases averted, we might be talking about something like 10, 15,000 deaths, and perhaps something like 60,000 or more cases of people getting seriously ill, needing hospitalization, and so on. So a huge strain on health services, or increase in the strain on health services. Now, these are very serious consequences. And then you have to say, so what are the negative consequences of some greater risk to privacy? And certainly in many countries now, they accept CCTV surveillance of public places. That's clearly an invasion of privacy in some sense, even if we are talking about public places here. And yet it's generally accepted if it turns out to be effective in reducing crime. So to me, I think a lot of people, when they worry about privacy and when they worry about the exposure of information, are really worried about the misuse of this information. So with the NSA exposures, they're worried that some government people in government may get access to this information. They may use it to blackmail people, perhaps, or they may use it to spy on other people. I think there was one case revealed of somebody who was using it to spy on his girlfriend and who she was phoning. So those, when you get the misuse of information, you can have very serious consequences that interfere with people's lives in ways that may be highly detrimental to the way they want to live. But to me, that seems the major issue. And if we can protect against the misuse of information, the fact that the information exists seems to be less of a problem. And that's why if we can have technologies that prevent that information from being misused, I think that we overcome a great deal of the issues. And then we can ask further questions about, well, is it worth actually the information being centrally gathered somewhere because of health benefits that might occur? So that I think that those are things that you need to have more consultation with populations. And again, as I say, it will vary in different countries. And I'm sure in some countries, people will say, yes, that's definitely worth it. I don't care that much about my data being in the hands of some agency because I trust them to do the right thing with it and only use it in appropriate ways. And in other countries, and again, I say probably the US is one of them, people are much more suspicious about government and probably would, more of them would say no. So those seem to me to be the basic questions. And as I say, it's just not obvious to me that loss of privacy in itself is a huge ethical problem, as distinct from the misuse of information that is being gathered. Thank you.
Okay, thank you. And next reminder, everyone, keep the questions coming in the Q&A, and they do get moved to answered as soon as anyone types anything, but they might still be live. So feel free to continue to upvote them and continue to read them also in the answered column. Just wanted to flag that for everyone. And with that, I will now turn over to Jason Hong, since there's no representing user acceptability because none of this tech works unless people use it.
Yeah, so I've been working on these sensor-based systems and usable privacy and security for about 15 years. And I wanted to share the results of a survey that my colleagues and I recently conducted about people's willingness to adopt contact tracing. This was a national scale survey in the United States with about 2,000 people and was representative of US Census data. So I'll start with the good news, which is that about 58% of people reported that they were willing to install contact tracing apps, which is in line with a lot of other studies about US population willingness. The other good news is that we found that people with higher household income, public transit users, and people living in urban areas and Hispanics were actually far more likely to install the apps. The bad news, however, is that we found that older people, women, and very strangely, essential workers were actually far less likely to install. Perhaps more relevant to this debate that we're having right now is that we found that the system architecture aspects of privacy actually had very little influence on people's willingness to adopt. Instead, we found that these individual differences played a much more important role. And so some of the individual differences include pro-socialness, which is basically how altruistic people are. Their COVID-19 risk perceptions, basically how seriously do they think that COVID-19 is. As well as technology readiness, which is fluency. So that's very similar to a point that was brought up earlier about, are we going to have a digital divide with respect to some of these technologies? And then we also found that factors like whether it's decentralized or centralized, or who the app provider was, actually did not have a very strong effect on people's willingness to adopt. Another really interesting part of our findings with respect to this discussion too is that we found that people were significantly more inclined to install the apps that collected location data. And so part of the reason for this is that location data can offer a lot of additional benefits. So for example, analyzing infection hotspots to let you know what places to avoid. But I should also say that the discussion of decentralized architectures, the intuition is actually correct, because we did find that people did have concerns about secondary use of data. So basically the reuse of data, and that would also reduce people's willingness to adopt. So I wanted to end with two major points here. The first is that it's possible that this debate about how to do contact tracing and exposure notification, it is important, but it also might be overemphasizing privacy at the cost of other very valuable features that might help with adoption and also prevent the spread of future pandemics, rather than just detecting after the fact that something happened. So I think what we also need to have in this discussion is, how can an underlying technical infrastructure help support more perceived benefits, again, to help with adoption and preventing spread? So to give two examples of this, one is Novid, which is a contact tracing app that was developed by one of my colleagues at Carnegie Mellon University. And one of the nice features they have in it is that it gives you a radar-like feature that sort of gives you a sense as to how close the threat of COVID is based on other people, like degrees of separation out from you. And then another one is location information. So again, there's legitimate concerns about how it can be abused. But the nice thing about location information is it can actually give you clear, actionable information about what to do. In contrast to exposure notification, which just tells you that something bad happened, but doesn't really adjust your behavior. It doesn't give you clear, actionable information as to what you might do. So I don't know what the solution is for the infrastructure. Maybe it's algorithmic. There might be, for example, multi-party computation or private matching, or maybe there's legal mechanisms as well too. But the point here is that these apps will not be useful if we can't really convince people to adopt. The other point I want to end with here is that we should also think a lot more about the design of the user interfaces, our messaging, and the marketing around the apps. And so, for example, one important factor we also saw was that convincing people that this app is going to be one that many other people will install was also an important factor leading people to want to install. And so, for example, a strategy we might consider for a future pandemic is if we can identify people who will be likely early adopters. So for example, pro-social behaviors or public transit or Hispanics, we might try to nudge them first to adopt so we can get higher numbers, and then think of alternative strategies for the late adopters as well. So that's the summary. This paper, we have an early preprint of it on arXiv, and I'm happy to share with you if you want. Just please send me some email. Thanks.
Thank you very much, and exactly 5 minutes for one person who's managed, and very pertinent to many things that many of us have been thinking about. So next, the perspective of law. Let's turn over to Jane.
Thanks so much. It's such an honor to be part of this very distinguished panel. So the popular wisdom when it comes to law as the backdrop for COVID contact tracing and risk assessment apps is that authoritarian countries like China have an advantage because they can engage in sort of massive digital surveillance for public health purposes and other purposes, while liberal democracies can't. And as is so often the case, there's some kernel of truth to that popular wisdom, but what we're seeing in the COVID era is that the obstruction to the development of really effective digital disease surveillance in the US and in other Western countries, the US and EU primarily, is much more cultural than legal. Indeed, I mean, you can think of well-functioning democracies that have gone much further than the US or the EU have been able to do with digital contact tracing and just digital disease surveillance of various sorts, to see that that's the case. South Korea, of course, is the example that's usually raised because it's democratic, but it also has very centralized, intensive use of digital surveillance that is quite transparent and highly effective and well received by the public for the most part. There are some scandals, but the public, for the most part, is behind the government's response. Israel, it sort of falls in the middle. It's also a democracy, of course. It also used a centralized program. It was less intensive than South Korea's, less transparent, less popularly supported, and in fact, the Supreme Court of Israel just ended the program for all except for people who test positive and then are obstinate when it comes to human contact tracing programs. Now, interestingly, though, an interesting additional data point. The Supreme Court said, well, one reason we're ending the program is that it's not very effective because only 30% of new coronavirus cases were routed to testing because of the contact tracing that the security department did. And, of course, I read that and I was like, oh my goodness, 30% of the discovered cases. And this is in a country that has very effective human contact tracing infrastructure. So in the US, the usual rules for surveillance and lots of other things get limited or even abandoned during times of emergency, including public health crises. So whether we're talking about the Fourth Amendment or even statutory regulatory laws like HIPAA, we do not even need, there's no legal impediment. We don't even need consent to disclose what would clearly be health records if the disclosure is likely to reduce the chance of an imminent threat to public health. In fact, we have, at least in the US, many affirmative duties that are often enforced through public right to sue that require doctors' offices or employers and others to let people know if someone in their office or in their facility has tested positive for a communicable disease. So if anything, the law might push disclosure. Nevertheless, I agree with James that abandoning the notion of consent probably isn't a good idea, and it might not be necessary because, at least in the US, so many times that data is collected and then reused or used intensively. It's done through a consent process, but one where there's sort of a quid pro quo, or a stick or a carrot attached to the decision. And that's okay under US privacy law, like consumer privacy laws allow for a service provider to say, hey, well, you let us track your data. By the way, if you don't let us, then something obnoxious will happen, or you can't use our service or whatnot. So that could happen here too. And for a while, I actually thought it would. I thought that what would happen is that there'd be some risk to retailers and employers if they didn't use an app. And so therefore, when you go to your Costco or Trader Joe's or something, you'd be asked to prove that you're using an app so that they can defend against any claims of negligence. None of that came to bear because for the most part, the understanding is that any company that complies with CDC guidance will not be found liable for potentially for exposing others that could have been prevented. And so there's the rub. The CDC and most public health agencies do not support digital contact tracing or digital surveillance applications. In fact, the federal government, the Congress, there were two different bills that were introduced in Congress, though they never made it out of committee, that each of them would have required opt-in affirmative consent to any sort of digital contact tracing style of app. EU is similar. GDPR could have been interpreted, arguably should have been interpreted such that you actually don't need to rely on consent. There's a lawful basis if the countries wanted, if public health authorities wanted to force users into adopting contact tracing apps, but that was just not a path that sort of would have been popular. So I think we're seeing, at a high level, we're seeing what Werner Troskin called the pox of liberty play out in Western democracies. So in the US and the EU, we are converging on sort of what I see as the worst of all possible worlds. Companies can and do track our location and other sensitive data for all sorts of relatively trivial stuff that helps us, that we think is in our individualistic best interest. Sometimes it's short-sighted, right? So sometimes we trade off our data for things that might not even be worth the trade. But in any case, there's not much incentive to solve communal problems, collective and communal problems. And then in fact, what's worse still is we tend to praise companies like Apple and Google for being bulwarks or bottlenecks to protect us from potential government intrusion. Now, Peter and Carmela both mentioned the Edward Snowden scandal, and I think that is the backdrop that really has affected our understanding of why people don't want to use these apps. But I've argued that disease surveillance really is meaningfully different from NSA counterterrorism surveillance, because unlike terrorist rings, who are very interested to know, would definitely exploit any transparency that's offered. The nice thing about fighting a coronavirus is that it doesn't know or care whether it's being surveilled and quashed, right? And so you can have legal constraints on a new program of digital disease surveillance that are much more transparent, much more accountable than the sorts of, than the secret FISA court and those sorts of institutions that we have to rely on to manage trade-offs between privacy and terrorist attacks. So one last point, thank you for indulging me. I know I'm a little late to it. The broader argument that once you build an infrastructure, we can't control it. There too, I disagree somewhat based on history. Our communications network as it is could be used much, much more than it is and has been for surveillance. Governments are constrained. Of course, things like the Snowden revelations show that they are sometimes used in ways that are surprising or fall outside the bounds of statutory and constitutional law. But governments do not use the technology that they have available to them, in part because of norms and in part because of law that does mostly constrain government actors.
Right, so thank you. In the interest of having any time for questions, Carmela, you have 2 minutes left on your clock, and James, you have 4 minutes left on your clock to respond to the respondents and to each other. After that, there will be opened up for the audience. So, and you're free to use less. So I think, James, we'd agreed that you'd go first if you want to use some or all of your 4 minutes to respond to the respondents and to Carmela.
Yeah, sounds good. Feel free to cut me off if I go over. So I think a trend that I think a few of the respondents have mentioned is that privacy seems different for different people. Like I think the way that we went into this, designing this, I thought that a lot of people would care about the architecture, like about the guarantees of privacy, and that I think has turned out to be exactly the opposite. So I think my takeaway from that is that the system we made was pretty close to correct, but we shouldn't necessarily have worried so much about perception issues as much as we did, and that we have room to optimize for actually the best system, even if it has some unintuitive design choices. And I think some of the discussion about centralized versus decentralized isn't actually as much of a trade-off as it would seem. I think all of the desirable properties of a centralized system we can do with a decentralized system, or at least most of them. And the outcome from people using it will be the same, but there's much less capabilities of mass surveillance. So I think a vast majority of the users, actually, we can have both. We can have the impact and we can have the privacy. Where that changes is for people that are infected. I think they're like the vast minority of overall users of the system, but it's very important that we have as much data as possible about them. And I think we should do our best to keep that private, to keep it secure, especially so people want to use the system and want to share. But I think occasionally there are trade-offs there. Like, for example, whether people are able to identify who exposed them. That was debated quite a bit in the early days. And for that reason, we don't currently share the time that you were exposed at. And we don't share location data. both of which could be done in a way that doesn't increase any surveillance, but might be useful for people that are getting those notifications and for contact tracers. So I think in the very least that those things should be shared with public health, and there are designs to do that so that the person getting the notification doesn't know those things, but the contact tracer they talk to will know where the contact happened, when it happened, and potentially to go even further and to just give those pieces of information. I think I had, for Carmela's point about collecting epi data, I think I mostly agree, but I think an opt-in model for that, again, gets most of the benefit. So if 90% of people don't share any data, and that's fine, but if we can get 5-10% of people to share relevant data, and they don't mind as much about privacy loss, then we can learn almost as much as about the disease as if everybody had. I think I'm just about out of time, so I'll pass it over to Carmela now.
Thank you, James. And I'm going to try to go very fast. And there are a lot of comments. Thank you guys for the input. So for the opt-out, I'm just going to be very brief. There's a huge discussion about opting out for us and everything. This is called dark patterns. We should have a discussion about when a dark pattern is allowed and if a dark pattern is allowed for public health. And this is a very different ethical discussion, right? And when we start running in that, we're going into a gray zone that is very big. So about this consent and opt-in mode. So the problem to me with this opt-in mode is first that opt-in can be very soon become mandatory. The moment that something is possible, it can be coercion, there can be peer pressure, there can be a lot of things. But also the problem is that consent to me is not good enough in this case, because you're not consenting about giving your data. You're consenting to give it the data of others, the data that are surrounding you. And I understand when Louise says, in contact tracing, right, there is this private relationship because you go to a medical place and you talk. Now, when we put technology as an intermediary, the conditions change, the boundary conditions change. This goes to a server that moves to another server. We have digitalized information that can be now processed in many different ways and in much different ways than when we kind of put something even in a CRM system. So we need to take into account all of these boundary conditions when we decide that we're going to move to that, and when we move the benefits against the harms. And again, I consider this extremely dangerous to start opening the gates from an opt-in because we can learn a bit. When you're actually sharing so much data, how many beacons you have seen, how many keys you have matched of people that maybe don't want to share with others that they were together at the place. And that right now contact tracers don't know, because there were the people that were behind you in the restaurant that you don't know their names, and they were actually having a date that they were flirting, and they didn't want to tell the contact tracer that they were with each other because their husband would learn. You know, there are a lot of things that we don't know, and we enter in the floodgates when we decide we're just going to share all of these things. And to finish with this share, I have heard in this discussion a lot of we don't value privacy. Let me remind you, it's not privacy what is at stake. It's freedom of the population to move, and the freedom of relationship, the freedom of association that we may break because we just put too much surveillance in place.
So thank you. And I just promoted the first question on the open list, Christoph Fraser, who has a question for Peter Singer. Christoph, you have to unmute.
Yeah, sorry, there's always one. So I agree about the locally differing values of privacy, and in the UK in designing the app, a lot of surveys were done. Most people trust the health system specifically with the data, not the government generally. And in fact, the majority of people actively want to share more data with the health system in order to improve health. So that, you know, on the other hand, in designing contact tracing, people globally, many people live in despotic governments, and there's no guarantee, you know, that data won't be used maliciously by governments, even in democracies like the UK. So Apple and Google had to design a system of global reach, and I have a lot of sympathy that that's very difficult, and actually a lot of respect for algorithmically making misuse impossible. do Apple and Google, I mean, effectively the precedent that was set here was that Apple and Google decided on the ethical system for the whole world. But is that, where's the accountability in that? I'm not particularly happy with those companies now taking over as the guarantors of what's right and wrong and what are our freedoms. Even if they made the right choice here. So how do we adapt to that local preference when we effectively have global tech companies?
Yeah, I agree with you that I don't think global tech companies really ought to be the ones making these decisions. And in one sense, they're not. I suppose they're making these decisions because national governments have decided not to take them on and try to control it. And that may be difficult, but it's possible. Here in Australia, as I think everybody knows, we've adopted a law which requires them, Facebook and Google say, to pay for the use of news services, to pay for the media. That hadn't been done before, but it's clearly within the sovereignty of the Australian government to do that. And the tech companies have the option of not operating in Australia, or not providing a news service. And for a while, it looked as if Facebook was going to do that, but in the end, they decided to negotiate. So you could be doing something like that in the UK. If you don't like what the tech companies are doing, you have the authority to change it, and of course they have the authority to decide not to operate in your country. I think that's the way the system works, and it is important that governments look at this and decide whether it's good or not. You also raised the question about, what about despotic governments? That certainly is an important issue, but it's I don't quite believe that if these contact tracing apps were not being developed for pandemic purposes, that China, say, would be unable to develop some kind of surveillance methods of its own that it used only for its political purposes. There may be some other countries that would not have the capability to do that, but I think the countries that we're probably thinking of here mostly would have that capacity.
Okay, so the next question, I have just brought Andreas Gebhard in to ask his question while live.
Hi guys, sorry about my video there. Hi. Yeah, I was just asking basically about early on in the development of DP3T and TCN and the protocols that then ultimately morphed into the Google Apple system. We did place a lot of emphasis on the system itself and the interoperation between the devices, but did not place particularly much effort on the interoperation with health systems, which you guys had noticed and mentioned throughout the conversation. I personally still think in hindsight that is the right approach, because we had to get that done first and then could discuss and work with health systems later. But I'm really curious to hear others' opinions there. Should we have put more emphasis on trying to interoperate with these more or less fragmented health systems right from the get-go? Would that have improved anything? Would that have improved adoption and interest from the public health side?
Michael? So I think, yes, we should have. And actually, the talks that I present is, I actually think that the apps were well ahead their time, because we put in place something that the environment was not ready to receive. There is not only the part of the integration, there is also a lot of communication with the contact tracer about what is good give and what is good not give. In the name of, when you scale a process and make it digital, you need to have a different risk imbalances, and that is the thing, that's negotiation. And we have learned from that, and now in the deployment, and I don't know if we call this a second generation app or not, the ones of present tracing, the ones that try to find out people have been collocated. With this, we have been having continuous conversation with contact tracers to understand what is the need, how can we really connect to their work process so that we don't interrupt and it doesn't create a burden, so that they don't reject the apps because they are going to receive so many calls. So we're changing the messaging, something that Jason said before, and a lot of things. And I think that like this second app is going to be much better accepted. And let me insert here another answer to the things I said before. We said we're going to find clusters. Cool. Let's find a way of finding clusters that does not rely on collect much more data from the data that we had for exposure notification to do that. There is a different thing that we need to do now, find the places where this happened and notify the people at those places. We can build another app that does that, but let's separate functionalities, because if not, we end up needing all the data and that ends up being the surveillance infrastructure.
James,
yeah,
go ahead.
Yeah, I think for the first month there, I think it was right to just design the system, but I think what we did wrong is stopping there. I think we should have started talking to more people at that point and looking at the failure modes and trying to find exactly where we're going to lose 70% of the effectiveness in each step and trying to optimize for that. Like one of the things we've been looking at recently is code entering. If only half the people enter it, we're losing a large chunk of the effectiveness, and it would have been good to have solved that problem a year ago instead of still trying to chip away at it now.
So for the next COVID, we're going to be in a better position.
Hopefully. I think Singapore did a good job at this. I think they really talked to the contact tracers and had buy-in from the very beginning on this, but it's a different situation.
And to chip in my own opinion, as an evolutionary biologist, when I see what's happening in Brazil, we might be looking at this pandemic still, that some improvements for things like this incrementally, it is not too late to improve this system if the Brazilian strain is as bad as it looks. Maybe Louise has more to say, but that's my evolutionary biology opinion.
No, I wasn't going to comment to that, but I was just going to say, I appreciate the idea that the notion that we were ahead of our time. I mean, public health is an entire enterprise with a lot of expertise, including in social behavioral understanding of what uptake would require. I'm not surprised at all that uptake would have been relatively low in certain places here. I mean, I think it's very challenging to innovate in a crisis. And I think in many of the more traditional aspects of public health and infectious disease control and respiratory virus control, even for masks, it was complicated, and masks clearly have an impact. Like, you could just look and see that a mask is going to be beneficial. So I think part of the challenge was also emerging evidence in an environment, an ecosystem in which there was a lot of emerging evidence, and people were kind of choosing which thing to bet their hat on, so to speak. And that was one of the challenges that, in addition, I mean, the health system required to actually respond to this pandemic was also evolving. So I think in retrospect, it would have been hard for you to probably really have more discussions early, but at the same time, I think it was just a chaotic environment of innovation, for an innovation to really land in a very impactful way. Again, I'm speaking for the US, which is where I've been mostly involved.
I want to clarify that what I refer that we could have done a much better job is not on the uptake, but is actually on such a stupid thing as uploading the code. And one of the biggest difficulties in Switzerland, as far as I know, in the whole of Europe, was for some medical doctors to actually find the website to produce the code and give it to the user. And that, with a bit more communication, trying to really understand how the workflow is and finding easier ways to do that, would have actually improved what James is saying right now, the number of people that can upload. And that was a bad technological decision, like Kim said. There's no shame in saying that. We did it bad because we went too fast. We thought that was easy. And that was actually one of the hurdles that effectiveness had, at least in Europe.
And I'll just say the UK did get above 70% in their latest preprint, to be congratulated, and a really amazing thing that other, and our own pilot in Arizona got over 50, did top 50%, but still it just 55% for us and for Germany. And these are the high numbers globally. So that has definitely been a limiting point, and that's just so close, and then it fails. I will go on to just one more. We are rounding up, but I'm just going to read one more question that's from an anonymous attendee, so I can't promote them, that Louise chipped in on, but I want to give others the opportunity to. Given that manual tracing is seen as private because a relationship's established between the tracer, who's from public health, and the tracee, does it make sense to establish a similar relationship for automatic exposure notification? That is, limit the sharing of automatic exposure notification information of diagnosis and contact to a specific person or group of people as a trusted representative of the system, be explicit about who exactly that individual is, and maybe the issue is that the information is to a faceless entity. So James, I think that question is for you, since you're the one advocating the sharing of information from digital to manual tracing.
Yeah, I'm not sure if I'm completely following the question, but I think the general direction is what I'm advocating for, where that information goes only to the local contact tracers. So you can set that up so the data is encrypted with the public key of the people you want to send it to. So in the same amount of data will be shared with contact tracers as though it was manual. I think one place where that falls down is that it doesn't seem person to person. It seems like you're just entering something into an app and who knows where it goes. But in practice, that actually is how it could happen. I hope that answered what the question was asking.
I think we are, with 6 minutes over time, I think we are wrapping up. Thank you all for coming. Thank you all the panelists for participating. I think it's been awesome, and we all agree on more than we disagree on, but there's enough we disagree on to make it interesting. So thank you, everyone.
Thank you. Yes.
Thank you.
Thanks for organizing this.